Medical induction and augmentation. And induction means mom's not having any labor at all. She comes in and we induce her. Augmentation is she's been having contractions, but it's just not rolling along as it should. So we augment her. There are different ways we can do this. You studied some of these medications in your medication chart. So prostaglandins cause contractions, and medications that are prostaglandins will cause contractions. Now, we know that during a women's menses, and if that woman gets cramps, then those cramps are caused from prostaglandins, okay? Think about this. What do we take, ladies, when you have a period and you want to stop that horrible cramping? We take antiprostaglandins to stop that. Advil, ibuprofen, some of the prescription ones. So for labor, we want to induce those contractions. We give her prostaglandins. Other ways we can, and you see Cytotec here, misoprostol, I don't think that's spelled correctly. Cervidil here, it's a gel insertion into the cervix. This is placed in the cervix. And then we also have a Cervidil, a different type of administration technique here, where the medication is actually placed in a little piece of, it's almost like a tissue or piece of cloth, and then it's hooked up to this string, and it's inserted and it's placed behind the cervix in the posterior fornix, and then the string is left in the vagina but placed so that it can be retrieved. Pitocin or oxytocin is another way we can induce or augment mom. Now, this is a very strong medication, and it's called a uterotonic. It is considered a high alert medication. It's a high risk medication. So much so that the initial dose is first diluted 10 units of Pitocin into 1,000 milliliters, typically. The initial dose is 0.5 to 1 milliliter per minute. And it's very slow. That's like 3 to 6 milliliters of diluted Pitocin solution per hour. And then after 30 to 60 minutes, we can increase it in increments of 1 to 2 milliunits per minute until we get her contraction pattern going as it should be. Now, once she gets to 5 or 6 centimeters, we can pull back on it, okay? And we would pull back basically at the same increments. It must be on an infusion pump. We do not give oxytocin without it being on an infusion pump because it's a high alert medication. Students, do not touch this med during labor because it can cause a hyperstimulation. And with a hyperstimulation, I want you to think what that means. What does it mean for mom? Okay, cramps. She's uncomfortable. They're coming close together. They're very big. But more importantly, what does it mean for baby? That means the baby's not getting a resting tone between contractions. That means that that uterus and that placenta is not getting reperfused. So think about what type of decelerations you might see with a hyperstimulation episode. Okay. Late decelerations, uteroplacental insufficiency. You can give Pitocin in the postpartum period. You can help with it there, but not when there's a baby on board. So some contraindications of induction augmentation is or are placental previous. That's where the placenta is implanted low. We'll cover that later. Abnormal presentations, Okay, baby's not coming out if baby is in a, or we're not going to induce if baby's in a breech presentation or a straight oblique presentation. If there's a high presenting part, that could be indicative of a CPD, cephalopelvic disproportion. So we may not induce in that situation. If mom has an active genital herpes, she is going to have a C-section. We don't want that baby coming through the birth canal and getting that virus into their eyes. We'll talk about the complications of that later for the newborn, but they're very grave complications. So we would not augment her or induce her. We don't want her to deliver vaginally if she has an active herpes going on. Previous uterine surgeries. If she's got that going on in her uterus or, on her uterus, then she is at a higher risk for a rupture. So we're not going to augment that person. Risks, again, are hyperstimulation and uterine rupture. So what is your nursing priority of care? We're going to watch that monitor, watch that baby, evaluate mom well, and make sure there is no hyperstimulation going on. Okay, make sure those contractions are giving baby a resting tone, make sure baby is responding well, and we're going to watch for bleeding to see if there's any rupture going on. Okay, increase the rate of Pitocin slowly for safety reasons. And baby must stay on the monitor. Amnioinfusion. This is where we want to infuse fluid back into the uterus. And it's done transcervically. What we do, a nurse typically does this, and they will guide the catheter in alongside the baby's head, and then they'll infuse IV fluid, normal saline, into the uterus. And it's used to treat things known to be associated with fetal compromise. For instance, variable D cells. Variable D cells, are caused by what? These sharp D cells up and or down and back up. Variable D cells, cord compression. So if we fill the fluid with, or fill the uterus with fluid, we want to suspend baby and hopefully get baby off the cord that's causing these variable D cells. It can also be used for meconium staining fluid. And again, we basically here we're flushing out the fluid, flushing out the meconium for when baby is delivered. Because when baby's delivered and baby's, wow, wow, wang, and then takes the first big breath, they can breathe in some of this mech stain fluid. And all of those particles, all of these down here that you see, can be aspirated, and it can cause baby an aspiration pneumonia. So we would suction this baby really well at birth, typically sometimes before the baby takes their first breath. And amnioinfusion is a procedure we could do to help flush out that meconium staining. Okay, it's a sterile technique. Risks are perforated uterus and infection. So nurses are trained how to do this and how to prevent a perforated uterus. There is a guide, a harder plastic guide, but that does not go into the uterus. We just thread the catheter through that. It goes up to the cervix. We thread the catheter through that. So it's kind of hard to perforate the uterus as long as that guide is not pushed up into the uterus. Okay, version is a procedure where the baby is turned typically before mom goes into labor. So we want to, if it's a breech presentation, we would like to turn the baby before they go into labor, head down, because breech babies, we used to deliver breech babies all the time in the old days. However, the problem with that is the baby's head is the largest, least pliable part to come out. So if we get the rest of the baby out and the head is too big to come out, we got a problem on our hands, okay? We want the head to come out first. We know if that head fits, we can get the rest of the baby out. Shoulders may be big, but there's certain little tricks up the trade we can do for that usually. So as mom goes through the latter part of her pregnancy, the last month of her pregnancy, we are checking to see, is that head down or not? And if it is, the physician will offer to do a version procedure, where what happens here is they go into the hospital or into a birthing center, and we do an ultrasound. We want to see how much fluid there is, because there has to be enough. We want to see where the cord is and where the placenta is. If everything, and the position of the baby, of course, if everything is just right, what the physician will do is we'll give mom a tocolytic IV, relax that uterus, and the physician will manually turn the baby from a breech position to head down, okay, as you see here. So hopefully the baby stays like this for delivery. Most babies do stay like this, okay? There are a few that say, baloney to this, I liked this better, and they flip back. So there's not 100% guarantee to this. We let mom know, but most babies do stay head down. All right, and again, these are our risks, similar type of risks, but that's why we use an ultrasound. If there is fetal distress, let's say we get a problem with a cord doing this, she goes into OR. So we do this close to an OR. Okay, technique is beyond 37 weeks. We do an NST with it too, see what baby's reactivity is. And then nursing considerations, education, assessment, and informed consent. Mom has to be informed of all these things. A vaginal delivery may require an episiotomy. An episiotomy is a small, like half-inch surgical incision, typically at the bottom of the perineum, or the bottom of the vaginal opening on the perineum. It could be a straight midline episiotomy. It could be a mediolateral episiotomy if we need more room. Sometimes they'll go diagonal, which can open up more room. These are more painful to recover from. A midline episiotomy typically is really not painful to recover from. In the old days, we used to do these routinely. We don't anymore. It is strictly on how big the baby is, if the baby's going to need more room, and the physician feels that this is a necessity. They'll typically talk with the patient about this beforehand. It's only done during second stage while mom is pushing. That head is down. You can see the head right here. And the head is putting pressure on that perineum. So it's sort of like if you've sat on your foot and you get a numb foot, and the blood flow stops to the foot. It's this situation here. The blood flow is basically stopped to the perineum because of the pressure of the head. So we don't get the tremendous amount of bleeding that we would if we were to do an episiotomy without the pressure of the head there.